Okay, thank you, ladies and gentlemen, for joining us today. Today we have an interesting talk by Dr. Fredrik Warnberg, joining us today from Gothenburg, Sweden. He will be talking about the magnetic technique, a novel and promising method for lymph node detection and tumor localization in breast cancer surgery. Thank you, Dr. Fredrik, for joining us, and the floor is yours.
Yeah, and thank you, Isham, for inviting me, giving me the opportunity to talk about the magnetic technique in breast cancer surgery. And first of all, I would like to say that I have no disclosure. We work very closely research-wise with the company in Cambridge, UK, that actually do the magnetic tracer and the magnetometer, but that's only in collaboration. So, okay, I will talk a little bit about the background for the magnetic technique, and then I will talk about different applications and central lymph node detection, how to use it to avoid unnecessary central lymph node biopsies in pre-invasive breast cancer. I will talk about using SPEO for sentinel node detection and MagSeed for tumor localization in combination, and how we can use this combination when we do the targeted axillary dissection, a way to avoid a full axillary clearance after preoperative chemotherapy. And finally, future perspectives, and if you have any questions. This presentation will be quite into the scientific part of it, and the hands-on part. I will, if you have questions about how actually to use the technique, I will answer those questions at the end, but I will be a little bit into it. So, generally, the first sentinel lymph node biopsy in Sweden was done 1999. So the sentinel lymph node biopsy, in my mind, it's a pretty new thing. And after 20 years of using sentinel lymph node biopsy, of course, people start to get new ideas and trying to develop things. From the beginning, the gold standard to find the sentinel lymph node was what we call the dual technique. Technetium, a radioisotope linked to a molecule, and in combination with a solution of blue dye. After only 4 years, the sentinel lymph node biopsy was routine in Sweden. And by then, about 95% of clinically node negative patients have had a sentinel lymph node biopsy. And as I said, dual technique from the beginning. In the beginning, we also did lymphoscintigraphy on all patients, as the left picture. After a while, we found that the sentinel lymph node was in the armpit in more than 98% of the cases, so we stopped doing that. And combination with the blue dye, the intensive blue colored dye. And the dual technique, it's very sufficient. We find the sentinel lymph node in 97-98% of the patients. So why do we really need a new method? That's what I will talk about. So the first supraparamagnetic iron oxide nanoparticles study was done in Sweden. The first study was done in 2014. And by then, it was 5 earlier studies looking at sentinel lymph node detection. And the tracer, it works in the same way as technetium and the blue dye. The particles are small enough to be drained by the lymph and big enough to get stuck in the first lymph node in the armpit. The tracer today is sold with the name MagTrace, but from the beginning it was called Sienna. The drawbacks for the dual technique is the availability of technetium in many parts of the world. You need a nuclear medicine department. It's the handling of the radioisotope is complicated. The half time of technetium is only 6 hours, meaning that you have to plan the injection with your program for the operation theater very closely. The drawback with the blue dye is that a bit more than 1 per 1,000 get a very serious allergic reaction. And due to this, we inject the blue dye when the patient is put to sleep with a free airway, and that actually reduces the detection of central lymph nodes because so I tried to share and that's
Terribly sorry about this.
yeah. Do you see anything now?
Yes, we see your slides perfect.
Okay, you see my slides.
Yes.
So compared to the, I continue. Compared to the dual technique, the logistics is easier, and it's because the tracer stays in the lymph node for quite a while, up to several months. No need for nuclear medicine department. Availability. I think it's only less than 10% of all hospitals worldwide that have a nuclear medicine department. We haven't seen any allergic reactions with the magnetic tracer. It's a little bit cheaper. On the backside, it's clumsier than using the gamma probe and technetium. So it's a bit difficult to get surgeons to change. There are artifacts on MRI if that's needed to be done post-operatively. And it's a discoloration of the skin, especially after breast-conserving surgery in some patients. But is there any effect on mammography and ultrasound of the magnetic tracer? No, there's no problem to inject it before you do a localization. There's no problem to do the specimen X-ray or ultrasound. Does the magnetic tracer affect histopathology? No. On the smaller part, you see the nanoparticles of iron oxide. They've been taken up by the macrophages, and it's subdermally localized, peritumorally, and don't affect the work of the pathologist. Same thing with the lymph nodes. Here you can see the nanoparticles. They are not taken up by the tumor cells. So some pathologists even say that it's easier to find micrometastasis when you have SPEO as the tracer. But there is artifacts. So this patient was injected preoperatively with quite a big volume of SPEO, and this is what you can see post-operatively. So is that a problem? And in Sweden, we very rarely use MRI in the post-operative setting. This is just a case. It's a woman who participated in a study. She had this Sienna by then, the SPEO, and after a year after breast conserving surgery, she came back on her yearly mammogram, and we found a 7 mm recurrence in her breast. And we did an MRI, and yeah, we could still see the artifacts from a year earlier. But when we injected the gadolinium, we could clearly visualize the recurrence on the MRI. But this is still not very well described. We have just finalized the study where we look at the postoperative effect, and we have followed it over time, but preliminary data say that there is no big problem to find recurrences. In the beginning, in the first studies, their recommendation was 2 milliliter of sienna diluted in 3 mils of saline and a retroareolar injection, a huge volume, and there were a lot of skin discoloration and quite large. You can see the left pictures, like 10 times 12 centimeter. They do fade out during time, and of course, if we have smaller volumes and if we inject the SPEO deeper, we get rid of most of the skin discoloration. I will show you some data on that. So I said the first study where we participated in Sweden, we call it the Nordic study. It was Swedish and Danish sites. And as all the studies up till then, we compared the dual technique with SPEO, and we used both methods in all the same patients. So each woman was her own control. And as all earlier studies, we could see that the central lymph node detection was equally good as the dual technique, and we could actually find the same nodes. The concordance was high. In this publication, we also did a meta-analysis of the 5 earlier studies, including our own study. Same results: good central lymph node detection, equally good to technetium, and same nodes were found. So at that time point, we introduced this as the routine method for central lymph node biopsy at our hospital, and by then I was working in Uppsala. And the following studies concentrated a lot on how to inject, what volume, when shall we inject it, and where. And this scented dose study, we compared 1.5 milliliter, no dilution, and a retroareolar injection with an even smaller dose, 1 milliliter, injected deeper peritumorally and a couple of days before surgery. And we could see that it doesn't seem like the volume is so important, but if we inject it in a couple of days before, the detection rate was better, and we still found the same nodes. So from 2019, we've used the smaller volume as our routine and the deeper injection, resulting in much less skin discoloration. Now we have just finalized a study where we even inject 10 times lower dose, 0.1 milliliter, 1 to 30 days before surgery, and it's injected in the skin, intradermally. And in the pilot study with 50 patients, we detected a sentinel node in all of the 50 patients. And now the largest study with 220 patients is performed to be able to change our routine. Of course, this gives skin discoloration, but with this small dose, if you inject it where you actually aim to do your incision, you can very easily remove the little skin staining. So that was the background and the sentinel lymph node detection. During the introduction of this method at our hospital, we saw that the tracers stayed in the skin for a very long time. So we thought, can we use this in any way? Maybe it stays in the sentinel lymph node for an equally long time. And the idea was to inject the tracer when we did surgery on patients with the preoperative diagnosis of DCIS. Up till then, in Sweden, we did more than 60% of the patients with DCIS actually had a sentinel lymph node biopsy, and we say an unnecessary lymph node biopsy, as they haven't got the available. They are not. You could say they can't metastasize, and even if sentinel lymph node biopsy is a much smaller surgery than an axillary lymph node clearance, it's not free from morbidity, and it also takes resources and it's costly. So the Sentinot idea was in, we call it high-risk DCIS, grade 3, large grade 2, or all patients undergoing mastectomy. We inject the SPEO at primary surgery, but we don't remove the sentinel lymph node. And if the final histopathology reveals an invasive cancer, so it's an upgrade to invasive cancer, then we do the sentinel lymph node biopsy, a delayed sentinel lymph node biopsy, and the node is already loaded with the tracer. So we started with a feasibility study with about 350 patients and 56 delayed sentinel lymph node biopsy. And by this, we could avoid more than 70% of the unnecessary sentinel lymph node biopsies. We found all sentinel nodes at the second surgery, even after mastectomy. And it has been said that after mastectomy, you can't do a sentinel lymph node biopsy. And costs were reduced. And very interestingly, the concordance was only, it was less than 50%. And now I talk about the concordance of the nodes detected by SPEO injected at primary surgery. And in this study, we in parallel, we injected technetium before the delayed sentinel lymph node biopsy. So by doing breast surgery, the lymphatics are changed. And if you do a delayed sentinel lymph node biopsy, you actually find, as we think, the wrong nodes. We've followed up on this feasibility study. So we call it Sentinot 2.0, the largest study to give statistical power. It's an international study, and we aim for 250 delayed sentinel lymph nodes biopsy after mastectomy and 250 after breast conserving surgery. The aim is to include 2,000 patients, and up till now, about 900 are included. And as in the first study, we look at the detection and concordance. So that was using this new method and using that the tracer stays in the lymph nodes for such a long time. At this time point, the company developed a paramagnetic seed or a clip, and it's called MagSeed, and it quite quickly it has become popular as a marker for non-palpable tumors. You don't need the guide wire. It also facilitates logistics. Our coordinators love this technique, but what we thought was that we wanted to go into it, as we thought, totally magnetic technique. So combining the tumor localization and the central lymph node tracer. So then we designed what we call the MAG Total study. It's a randomized study. We randomized between the MAG seed and what we used then, the guide wire, and both localization methods were in combination with the magnetic tracer. We published this in JAMA Surgery just a couple of months ago, 400 patients, and we couldn't find any statistically significant differences in reoperation rate or in specimen volume or specimen weight. And on the good sides, we found that the operation was statistically significant shorter, but it was only 5 minutes shorter, but also the logistics were considered much easier of both radiologists, surgeons, and our coordinators. So in this combination of magnetic clip and magnetic tracer, we put the seed ventrally in front of the tumor, and we injected the tracer behind the tumor, because with a magnetometer there is a signal that is a bit difficult to differentiate between mag trace and mag seed. This combination of mag seed, the magnetic clip, and the magnetic tracer is now used in what we call targeted axillary dissection. So this is when you do surgery after preoperative chemotherapy. These are more advanced cases, and they often have lymph node metastasis at the time of diagnosis. So when you give the chemotherapy, you know that the patient has a lymph node metastasis, but the treatment is so effective so that the lymph node metastasis actually disappears in more than 60% of the cases. Still, we want to stage the armpit. So the targeted axillary dissection is you mark one of the metastatic lymph nodes before chemotherapy, and it's ideal to use the magnetic clip, because then you don't need to mark your marking after chemotherapy. So a magnetic clip in one of the metastases, and then in this TAD or targeted axillary dissection, you also remove additional central lymph nodes. And in this study we've been conducting, it's a pilot study with 80 patients, we actually injected the magnetic tracer at the same time as we put the seed in the lymph node metastasis. So 3, 4, 5 months before the axillary operation. And the whole idea with a targeted axillary dissection is, if you can show that the metastases are gone, you have a complete pathological response in the armpit, you don't need to do the full dissection. So just to illustrate, you put a mag seed in the metastasis guided by ultrasound. If you want, you can actually localize and visualize the lymph nodes with an MRI. So the tracer was actually made as an MRI contrast from the beginning, but here you inject the tracer in the parenchyma in the breast, and just a mammogram showing the ordinary tumor clip areolar tumor and the MAG seed in the lymph node metastasis. And I'll talk you through this picture. This is all lymph nodes that were removed, the additional lymph nodes. So this is not the index lymph node metastasis with the MAG seed. This is lymph nodes, and just as in the study on DCIS, the magnetic tracer was injected before chemotherapy, and then at the time of surgery, we also injected technetium. So what could we find? First of all, we found more nodes with the magnetic tracer. So all in all, 159 nodes were found with SPIO, and 95 nodes were found with technetium. And the blue circle, that's all nodes that were found with both techniques. And the yellow, that's how many of the nodes that were localized with technetium were actually also found with the magnetic tracer, and that was 81%. So concordance, 81%. And then, interestingly, of all nodes found by the magnetic tracer, the reddish circle or ellipse, of those nodes, only 48 were also detected by technetium. So reversed concordance, only about 50%. So this is like DCIS and breast surgery affecting the lymph drainage. Our hypothesis is that the drainage is actually affected by the chemotherapy. It makes the lymphatics fibrotic, the lymph nodes fibrotic, and we will continue doing a larger study on this to actually prove our hypothesis that if you do your central lymph node dissection with a tracer injected after chemotherapy, you actually risk to find the wrong lymph nodes. So finally, the future. What's next regarding the magnetic technique? We've started to do this with melanoma surgery. And when you have a melanoma, the lymph drainage is not as clear as in breast surgery. We almost always have the lymph node in the same axilla, but here the lymph node can be in any of the four major lymph compartments. So you inject the tracer and you do an MRI to see where you should go to find it. So that's what we have started with. There are also studies on colorectal, on gynecological cancer, head and neck. So this will improve, I think. The combination of MAG seed and magnetic tracer, it's actually only we that do this at the moment, but people will of course see that it's much convenient to use the same machine for finding the breast tumor and the lymph nodes in the armpit. And there are very, very preliminary but promising data that if you inject SPIO and then do the MRI of the axilla, maybe we can develop a technique so we can visualize not only the lymph nodes, but the lymph node metastasis. And if we could do that, we could actually spare the patient from a central lymph node biopsy. So this is something we will look into in the future. And technically, I said I would come back to the proper surgery. The probe, it's clumsy. It's take 7 seconds to calibrate, and you have to calibrate it a couple of times during surgery. You can't use metallic instruments. And people, when comparing it to gamma probe and technetium, it's not that good. But the technique will develop. There is a new probe that actually can differentiate between the magnetic seed and the tracer. It's much quicker to calibrate. It's a lot of improvements, but it's only approved in the US at the moment, not in Europe. There is a new mag seed, not on the market, but studies are ongoing to make it CE marked so we can use it, and it's less MRI artifacts. It could more easily be used as a localizer for the tumor, for the breast tumor, before preoperative chemotherapy. Also, the plastic instruments, they have improved. For the first 8 years, I didn't use any plastic instruments. I just removed the metallic instruments and used my fingers. But now the instruments start to be good enough to actually use. And to round up, yeah, the magnetic tracer, it's well established as a tracer for sentinel lymph node biopsy in breast cancer. And the sentinel lymph node detection is equally good to the former routine dual method. MagSeed, the magnetic clip, it's established for localizing non-palpable breast tumors, and I would say it's doable to combine it, but we need to find a better way to combine it to make it easier for a if the surgeon is not very experienced in the magnetic technique. The MagSeed and SPIO combination in the armpit is super easy, and we use it for the targeted axillary dissection as a routine today after preoperative chemotherapy. This Sentinot, it's used in many places. For example, in the US, as the routine method to avoid unnecessary sentinel lymph node biopsies in DCIS. And as I said before, there is ongoing research on many other cancer forms where we need to do sentinel lymph node dissection. So thank you very much for listening. So it was good not to be hacked the last 20 minutes.
No, we had a spammer amongst us, but glad that got sorted. So I have a question regarding the Sentinot. As I understood, you first inject you do the dual technique, and then you mark which lymph node, so then you put the MAC tracer. So if it's positive for cancer, you then come back and go directly to the MAC tracer. That's correct?
So now I can't see you, but I hear you clearly. So if
you stop sharing the screen, you will see me.
The question was the Sentinot technique.
Yes.
So that's for DCIS.
Yeah.
Then we only inject the magnetic tracer at primary surgery, and in about 75% of these patients, they are not upgraded to invasive cancer, so then we don't do anything in the armpit.
Yes, but how do you localize the lymph node during the primary surgery?
Well, we just inject the tracer peritumorally in the breast.
Which tracer?
The magnetic tracer.
Okay.
Because it stays, we saw that it stays for several weeks. Now we know that it stays for several months. So in the in the study, we start the operation by injecting the SPEO, and at the end of the surgery, we actually listen with a gamma with a magnetometer, the CentiMag probe, to see that we have a signal in the armpit. If we have a signal, we know that we will find the central lymph node. For us, it takes 4 to 5 weeks to have the final histopathology, and then plan her for delayed central lymph node biopsy.
Okay, but I mean, maybe another way we can do it is, if you don't have this magnetic tracer, is to localize the sentinel lymph node using the usual methods.
Yeah, but the half time of technetium is only 6 hours. So
yes, but then you put a mag seed or a clip.
Well, we don't know. The mag seed we use when we have a metastasis. But I think if you have mag seed, it's not that difficult to get mag trace, because then you have the CentiMag and you have the technique.
We don't have them yet here, but I think today we had a talk about something similar in our hospital. So maybe we'll have them in the future. So for now, we use wired localization. Until now, we use still wired localization.
But I mean, this is not about metastatic lymph nodes.
Yeah, I understand.
DCIS, if you do an ultrasound, you have no idea which node that will turn up to be the central lymph node. So
yes, I understand.
You can't mark it in that way. And of course, maybe this works with blue dye. No one have tried that. I don't know for how long it stays in the node. I know that the mag trace, the magnetic tracer, in some patients, it stays in the node for more than a year.
But it stays in, if you leave it for a long time, it will stay in the same node. Will it not disseminate into other nodes?
So what we saw in the study where we injected SPEO before chemotherapy. So we did the central lymph node biopsy after about, let's say, 4 months. We had very slightly more nodes with SPEO that stayed for 4 months than with technetium that we injected the day before. But we have also seen, we did MRI on not very many, but about 5 patients in that study. We did an MRI after SPEO injection, and then another MRI after chemotherapy, and it was the same nodes were localized. So that it stayed in the same nodes. 5 patients. I don't have any good proof on that, but preliminary data stays in the same nodes.
Okay, let's see if anyone in the audience has a question. Please raise your hand. Any question from the audience? Please raise your hand if you have a question. Any questions? Well, I guess it was a straightforward talk. And what's the incidence of the DCIS patients upgrading to cancer? 25%, you said?
Yeah, in the study, it's 20 to 25%, but they are also selected. Grade 3, large, grade 2, and large enough lesions motivating a mastectomy. So it's a little bit higher than in the general DCIS population.
Okay. Okay, so it looks like we don't have any other questions apart from mine. So that was it. So Thank you, Dr. Fredrik.
Thank you.
I hope you enjoyed it as much as we did.
Yeah, everything about the hacking.
Yeah, that was a special part. This
Yeah.
will give us something to remember.
Now there's a raised hand.
Where is it?
Oh,
I,
it went away.
actually, I can see. Yeah, if anyone has a question, last chance to raise your hand. And if you liked it, maybe we can do another talk maybe in the future in a few months if you have the time.
Are
Any
you
other
asking
topic?
me or the audience?
No, you.
Yeah, this was great fun. I
Okay.
miss the interaction with the audience, but here we are.
We have a question from Dr. Heba Gamal.
Yes. Hello. I would like to ask about the Mac seed. Can we localize it with our hands, or we need a probe for it?
If you can localize it with your hands.
Yes. Is it something that is being felt, or it is
Is it
like
palpable?
is it palpable, or we need a probe to localize it?
Yeah, I would say you need a probe. It's 5 times 0.8 millimeters, I think, and
Yeah.
we put it close to the tumor, so quite often deep in the breast or in the armpit.
Yeah, and for the targeted axillary dissection, can we put a Mac seed too in the lymph node? I mean, why do we need a tracer, a Mac tracer? Why don't we use the same technique for non-palpable breast tumors, and we do it the same thing in the axilla?
So there are places that do targeted lymph node dissection. Then, of course, you just put the mag seed in. In Sweden and in many other places, we call it targeted axillary dissection, and that includes index lymph node and additional central lymph nodes.
Yeah, but here we don't need the tracer. I mean, or just we need it for the sentinel lymph nodes.
I mean, you can use any tracer. You can use the blue dye or technetium, but we thought that using that just having one machine doing both central lymph nodes and index lymph node, it's very convenient.
Yeah, I'm talking because we have here limited resources in Egypt, and we even don't have the blue dye for the time being, and we just forgo the sentinel lymph node as a procedure when we don't have these resources. So I was thinking about one method to fit all. That's it.
So how do you define your central lymph nodes? Do you do an axillary sampling, removing a couple of nodes?
Unfortunately, we just do an axillary evacuation.
Yeah.
Because you cannot do a sampling without sampling would be gambling.
Yeah.
If you don't have the proper method to do.
There are centers here using the methylene blue dye, though it has a very high false negative rate.
Yeah.
And when we don't use the methylene blue dye and we don't have any other resources, we usually go for low axillary sampling, which is level 1 and 2 axillary dissection.
Yeah. Yeah. I mean the mag seed is rather expensive. In Sweden, we pay 350 euros. It's about $350. The mag trace, the vial is 2 milliliters, and now the study we are doing is 0.1 milliliters. So that's we can really use small doses. But that will certainly mean that the company will sell. They will
not sell that
adjust
many.
the vials, I think.
Yeah.
So when we have looked at economy, we have compared with the isotope, and then it's a little bit more cheap. still, of course,
And
it's
compared with
costly.
the indocyanine green dye, is it less expensive or more expensive?
Then what? Then the
ICG.
Indocyanine green, ICG.
oh, I actually don't know what the cost is for that. I haven't looked into that.
Yeah, we have looked into that here in Cairo in National Cancer Institute.
Yeah,
We didn't buy still the machine, but it cost the machine to 1.5 million Egyptian pounds. But the problem is with the dye itself, it's very expensive. I think the vial is for 5,000 pounds, which is quite expensive for one patient.
yeah,
So all methods are expensive for us, and what I'm
Yeah.
trying to say is that we need something that is that can be used in limited resources, and until now we don't have anything that can fit our resources except the methylene blue, which is very cheap, but
yeah,
on the expense of its sensitivity and specificity in sentinel lymph nodes.
yeah. The probe, the Centimag probe, it's about $30,000.
Oh, wow. This is quite expensive.
Yeah, it's about the same as a gamma probe.
Yeah, but what about you already said that the magnetic seed itself is also expensive.
Yeah,
I mean, for the tumor localization, I think we are using now the wire localization, which is quite cheap.
yeah,
The problem is with axilla, how to stage it without any dye, blue dye, or any dye, or even the magnetic seed. I was thinking about the carbon particles, but I didn't do a search on literature about the its use in the axilla.
There was a hospital in Stockholm, Sweden, participating in the tattoo study with coal, and they stopped doing it because there was coal all over the place. They've used coal since the 1970s for breast localization, and they think that works very well. But in the axilla, they are not pleased, and they've started to do the mag seed.
Yeah. Okay. Do you have a video for the whole technique or to show to us?
No,
Okay.
I have not.
Okay.
I suppose the company might have one.
Yeah.
And
On YouTube, you must find many videos on YouTube if you just put Mac Seed or Mac Tracer, because I see them whenever I go to the conferences. They're displaying everywhere.
Yeah. Okay. Thank you very much for your lecture. It was really very excellent. It was excellent. Thank you.
I have a question to you. I
Yeah.
mean, we don't do it in Sweden, but these magnetic seeds, they should be reusable.
Yes. But how will you do it after putting it inside the patient? Can you re-sterilize it? And you're saying it's very, very minute particle. How can you get it even? Because you get it inside the tissue and you send it for
I'm sure
pathology.
here in Egypt we would find a way to sterilize it, because here we sterilize everything. The ligashore, the harmonic, we sterilize everything.
So we are not allowed to re-sterilize the mag seeds. So we just threw them away, but the pathologist will easily find them when they do their examination.
I don't think it's a good idea to re-sterilize a mag seed and put it again in another patient after being sent to the pathologist and after being inside the patient for months or weeks. I think this is too much. We don't do this even in the instruments. There are some instruments that should be just disposable, not for re-sterilization.
Yeah, and the mag seed it's not very the surface is a little bit scrumpy. So
Yeah.
it makes it more difficult to sterilize.
Yeah.
No?
Yeah, it will cost more after giving more diseases to the patients, blood-borne disease and things like this.
Yeah.
Yeah. So it will be costly, but on the long run.
I just try to be innovative.
Yeah, you are. Okay. Thank you.
Yeah, thank you.
Okay, any other questions? Last chance. If you have a question, raise your hand. Okay, so that was it. Thank you, Dr. Fredrik. I will send you another link right
Okay.
now.
Yeah.
And thank you, everyone, and good night.
Good night.
Good night.
Good night.